All right, it's the top of the hour, so we'll get started. So thanks everyone for joining our webinar. Welcome. Today we have a webinar on adult refsum disease from a clinical practice perspective. I'm Christy DeMarco, the founder and president of Global DARE Foundation, and I'll be your host today. We are honored to have Dr. Radha Ramachandran, who is the consultant metabolic medicine clinical lead and consultant in adult inherited metabolic disorders from Guy's and St. Thomas NIH Foundation Trust in London, England, where she has been working since 2013. Radha has been involved in caring for patients at the world-renowned Refsum Clinic in Chelsea, Westminster since 2014, before it was amalgamated with Guy's and St. Thomas, which has the largest cohort of Refsum patients in the UK. Radha is a specialist in the chemical pathology and metabolic medicine. Before I hand the presentation over to Dr. Ramachandran, I'll share a little bit about Global DARE Foundation. Let me switch the slide here. Global DARE Foundation was established in October 2019. DARE stands for Defeat Adult Refsum Everywhere. Our mission is to promote worldwide awareness and better quality of life for all who are diagnosed with adult refsum disease. Our goal is to support research, education initiatives, awareness campaigns, and advocacy. You know, driving research is at the center of what we do because we dare to believe in a cure for adult refsum disease. Dr. Ramachandran is supporting Global DARE Foundation's mission by being a valuable member of our Medical and Scientific Advisory Board. With Dr. Ramachandran and other members of our Medical and Scientific Advisory Board, we are raising awareness for refsum, driving better treatment and care, and reinvigorating the research into better therapies for adult refsum disease. So now on to some housekeeping details. All participants are in listen-only mode. There are a few ways that you'll be able to ask the questions during the presentation. So participants following in on Zoom can type their questions in the Q&A box at any time during the presentation, or by raising their hand by pressing the Alt-Y button on the keyboard. Participants joining by phone can press *9 on their phone to raise their hand. After the presentation, I'll be moderating the questions, and I'll start to ask the questions in the Q&A box first in Zoom, and then go to the dial-in participants, and then to the online participants that raise their hands. So today's session will be recorded and will be available for later viewing on the Global DARE Foundation website. So now I'll hand the presentation over to Dr. Ramachandran. She's going to share her own slides, so let me stop sharing.
Perfect. Can you see my slide?
Yes, I can, and I can hear you just fine.
Brilliant. Excellent. Thank you so much, Christy, for organizing this, and thank you for inviting me to speak today. You've already had a number of lectures which have detailed the biochemistry and the pathophysiology of the disease. So I'm going to limit myself to discussing about a few aspects of clinical practice, particularly focusing on why we do what we do in the clinic. So ours is a bigger adult IMD service, and we look after refsum disease patients within the umbrella of that service. So as we all know, adult refsum disease, it's an autosomal recessive condition. It is a peroxisomal disease, and it occurs due to a deficiency in the phytanyl-CoA hydroxylase enzyme. It is a very rare condition. We think the prevalence is about 1 in a million. We know that early diagnosis results in improved outcomes, and therefore I'm going to concentrate a little bit for the first few slides on diagnosis of adult refsum disease. So this paper, I think Dr. Leroy referred to it as well in his presentation. It was published in 1992, and they looked at the eye disease in refsum disease. And one of the striking comments in that paper was to say that there was a diagnostic delay of, on average, 11 years between the first development of eye disease and the diagnosis of adult Refsum disease. So 20 years on, we conducted a survey looking at the practices of clinicians in ophthalmology departments across Europe. So 33 clinicians from 13 different countries took part in the survey, and the results showed that 70% of the respondents had been involved in the care of patients with adult Refsum disease at some point in their career. 60% felt that ARD was underdiagnosed, and strikingly, only 30% felt that they were confident in diagnosing patients with adult Refsum disease. So the standard teaching is that patients who present with retinopathy, it is important to look for other corroborative histories such as anosmia, bony malformations, deafness, neurological manifestations, ichthyosis or dry skin, and of course, family history. So let's just look at some of the other symptoms that occur in Refsum disease. So this is a graph. On the x-axis, you've got age in years, and on the y-axis, you've got the number of patients. And the different symptoms of adult Refsum disease are represented by different colored lines. So as you can see, people present with retinopathy mostly, and the number of people having retinopathy increases with age. As far as we know, 100% of the patients who were diagnosed once their symptoms started do have retinopathy. Anosmia is present in almost all patients. However, we have to remember that this figure is based on the UPenn scratch card diagnosis of smell test rather than patient subjective feelings, because that can be slightly more difficult to assess objectively. Neuropathy was present in up to about 65% of patients, and only about 20% of our patients had dry skin. And when we talk about the classical bony malformations that are seen in Refsum disease and that are shown in pictures here, I think it's important to remember that these are all not obvious visually many times, and one needs to take an X-ray in order to actually see the shortened metatarsals. And even on X-ray, only about 30% of patients present with these bony malformations. So really, retinopathy could be the only presenting symptom in patients with adult Refsum disease and precede any other symptomatology by many years. And just to highlight that, I thought I'd present the case of one patient who has not been long referred to our service. So he's a 30-year-old gentleman, retinopathy since the age of 18, no other features of adult Refsum disease, no family history, and he was entered into a research study where a genetic panel was analyzed. It was on the genetic panel that two mutations in the PHY gene were found. He subsequently had Phytanic acid levels done, which was only 10.62, reference range 0 to 10. And I remember speaking to our biochemist then, who felt that actually 10.62 was a very borderline result, and they were more used to seeing Phytanic acid in the hundreds, and perhaps would have doubted this result if they had seen a result without any history. On questioning after the genetic diagnosis was made, the patient felt that they might have had a blunted sense of smell. There was no other history suggestive of adult Refsum disease. We sent off a skin biopsy and Prof. Wanders to his lab, and it was confirmed to be adult Refsum disease. We did think about whether we should initiate a low Phytanic acid diet, and we did. On a loose low Phytanic diet, his Phytanic acid level is now less than 5 micromoles. In the last year, we've had another referral from the eye department, very similar history, again, of retinopathy, no other symptoms or family history, adult Refsum disease on the retinopathy gene panel. And in this case, again, the Phytanic acid levels were only just above the reference range at 22.5. We then looked at the literature, and there is one further case report in the literature, which was published in 1990. The index case had retinopathy and cardiac failure, but Phytanic acid was consistently normal. He was diagnosed with ARD only after his older sibling presented similarly with cardiac failure, retinopathy, and raised Phytanic acid levels. So I think the take-home message here is that retinopathy may be the only clue. Plasma Phytanic acid levels, of course, they are increased in most patients. However, we now recognize they might not necessarily be increased very high. And also, increasingly, patients are avoiding red meat, and people use alternative sources of milk. And so it is quite possible that patients whose Phytanic acid levels might have been borderline on meat and milk, like our previous two patients, actually might have normal Phytanic acid levels. Pristanic acid has always been undetectable, and it's a useful marker to measure in conjunction with Phytanic acid. But we feel that with the increasing availability of genetics, it is likely to give us a higher pickup rate and also more milder and varied phenotype. So our recommendation would be that any patient who has a retinopathy where the diagnosis is not secure, adult refsum disease should be considered as part of a differential. And I feel that the future diagnostic journey is likely to be a genetic panel in the first instance, followed by biochemical confirmation with plasma Phytanic acid and Pristanic acid. And of course, the genetics can throw up variables that have not been identified before, and therefore skin biopsy is an alternative to confirm the diagnosis if there is any ambiguity. So I think there has been, particularly from the patient community, in terms of whether we can make a pre-symptomatic diagnosis in patients with Refsum's disease. There's very little in the literature, but there is this particular case report that actually was brought to my attention by Christy, so I'm very grateful for that. It's a really important paper, and I think the outcome of the patients from this paper will be important for us even in the years to come. So what this paper talks about is a lady who had Refsum's disease, and she was married to her cousin who was heterozygote for Refsum's. She had 7 pregnancies and 8 conceptions. The first conception had a prenatal diagnosis of ARD, unfortunately had a spontaneous abortion. The second pregnancy was a carrier. Third pregnancy was found to have adult Refsum's disease and was medically terminated. And then subsequent pregnancies, the patient decided to go ahead with the pregnancies, and therefore no prenatal diagnosis was made. 2 of the girls were found to have adult Refsum's disease, whereas the others were carriers. So I've just boxed in the Phytanic acid levels of the 2 girls who were found to have adult Refsum's disease. And as you can see, the levels of Phytanic acid are slightly raised in both the girls, measured at birth. Important to say that mum's levels were mostly under 200, but in the 5th and the 7th pregnancies, they did go up higher to up to 500. So if we just compare the 2 girls who were homozygote, important facts are both of them had slightly raised Phytanic acid. Both of their levels normalized later on in the neonatal and early neonatal period. Both of them were put on low Phytanic acid since birth. However, the Phytanic acid levels did start to rise again slightly earlier in the first child compared to the second. Both of them are essentially normal at the time of the publication of this article. They were 5 and 3 years old. They haven't mentioned retinopathy specifically, but have noted the normal physical and psychomotor development in the 2 girls. And they felt that the levels of Phytanic acid in the children had increased, possibly because of deviation from the low Phytanic acid diet. So what can we conclude from this? I think we can conclude, or we can safely hypothesize, that perhaps moderately elevated Phytanic acid levels in mum pose low risk to the fetus. Or the babies seem to be normal development despite the slightly raised levels of phytanic acid in mother. We know from other inherited metabolic diseases that the risk of acute decomposition in pregnancy is greater, and therefore women who are pregnant need to be carefully monitored and managed during pregnancy. I think what this paper also suggests is that there is some degree of transplacental crossing of the phytanic acid. We think that the increased phytanic acid in the affected babies is actually more a reflection of the adult Refsum disease and the high phytanic acid levels in the mum. We think that adult Refsum disease babies of heterozygous mums are unlikely to be born with high phytanic acid levels. And we don't think that biochemical newborn screening for the general population is an option because phytanic acid levels are unreliable, and therefore there's likely to be false negatives, or it's likely to reflect mum's phytanic acids. And we also think that it's likely to, because of the very low prevalence of ARD in the general population, the risk of false positives are also possibly higher. And therefore, at this time, newborn screening for the general population is probably not recommended, but any babies who are high risk, we would advise going for genetic testing as first line and phytanic acid as second line for testing for these patients. So in terms of treatment, there are quite a few unanswered questions, again, with regards to the low phytanic acid diet. However, I've tried to summarize some of the research on which we base our current teaching. So the low phytanic acid diet, the main aim is to ensure that there is a positive net elimination of phytanic acid from the body, i.e. where the patients are excreting more phytanic acid than they are taking in. And the reason for that is because this is the picture. I don't know if you can see my arrow, but this is a picture of the schematic diagram of phytanic acid. Normally, the mitochondria break down the fatty acids 2 carbon by 2 carbon from this end of the fatty acid. However, just because of the structure of phytanic acid, the mitochondria can't do that immediately. And therefore, as we know, alpha oxidation is required. This happens in the peroxisomes. And this is what is affected in Refsum disease. And so the body is quite clever in that it tries to chop the fatty acid up from the opposite direction using what we call omega oxidation. So this was a paper published in 2003 by the Refsum Disease Clinic, and they looked at the phytanic acid levels, which are shown here as red diamonds, and the blue triangles are the corresponding methyl adipic acid, and it's not actually the concentration of the 3-MMA. It is more a concentration of the proportion of phytanic acid that is excreted as 3-MA. So the x-axis has got the concentrations and the y-axis is the days. And as you can see, as the concentration of phytanic acid is higher, so is the 3-MAA levels. And then as the concentrations decrease, the levels of the 3-MAA also decrease. So the conclusion from this is that the omega oxidation does play a significant role in elimination of phytanic acid. It can provide an alternative pathway in patients with ARD. Indeed, the levels of 3-MAA in patients with ARD are increased versus normal controls. And we also know that the levels of the 3-MAA correlate with plasma levels of phytanic acid. But there is a caveat in that there is a threshold capacity of roughly about 6.9 milligrams of phytanic acid a day. However, I want to draw your attention to the range here between 2.8 to 19.4. And this was looked at in 11 patients who underwent strict dietary therapy, and the estimates of excretion of 3-MAA was made in those patients. So that is the rationale for limiting the amount of phytanic acid in the diet to 10 milligrams a day. So The next question that we get asked, or that has been debated recently, particularly, has been about the fruit and veg in the adult Refsum's diet. So the original diet for adult Refsum's disease did not include fruit and veg, and it was a very restrictive diet. However, there was a study done in 1988, and it involved one patient. And what they looked at was to look at fruit and veg with high phytol levels. These are phytol levels that are bound to chlorophyll, which humans are not thought to be able to process, but low free phytol levels. And they introduced fruit and veg into the diet of this patient and monitored the clinical progress and plasma and adipose phytanic acid levels for 18 months. And what they found was the patient remained clinically stable and the phytanic acid levels showed no change. And therefore, given how restrictive the previous diet was and the impact on quality of life, they felt that it was reasonable to introduce fruit and veg into the adult Refsum's disease diet. They then evaluated how effective this diet was again in 2010, where they looked at roughly about 20 patients who were attending the clinic, and they found that the diet did indeed bring the phytanic acid levels down, with 30% of patients normalizing their phytanic acid levels. A further 55% had levels that were consistently around the 150 to 200 micromoles per liter. And then you had a small percentage whose levels remained above 500. They also looked at the mean half-life of phytanic acid in these patients who were on the long-term diet. And what that means is how long did it take from the first time they started the low phytanic acid diet to when their phytanic acid levels in the plasma halved. And that was roughly about 40 months. And so that seems like a really long time. But then this study, which was done much earlier in 2003, looked at 11 patients. 2 patients' data is not available on this table because they were lost to follow-up. So 9 patients' data is available on this table. And what they did was they put them through intensive dietetic therapy for 6 weeks. So a dietitian would call every week, and they recorded their food diary for 5 days during that time. And having done this intensive therapy, what they found was that on average, phytanic acid levels roughly halved in 23 days. More recently, this paper has been published, and I think Professor Wanders also referred to this paper. And what they talk about is phytol fatty acid esters in vegetables, which are not chlorophyll bound, but might be metabolized in the human gut to release free phytol, which might be responsible for increasing phytanic acid levels. And based on this, we're now working with Dr. Anne Moser to get the phytol fatty acid ester content of vegetables to see if this will actually have an impact on our diet and our dietary advice for these patients. So what are the current limitations of our dietary therapy? Firstly, I think the most important is that the information on phytanic acid levels in food is limited. People's dietary habits have changed. The way we farm has changed, and therefore quite a bit of work needs to be done on this. And hopefully we will be doing that with the help of Dr. Anne Moser. We've also recognized that the omega oxidation capacity in patients varies, as does possibly residual enzyme levels, and therefore further research to enable personalized dietetic advice for patients would be very welcome, and we would be working towards that. And just a brief slide to just highlight the modifiable and the non-modifiable risk factors for high phytanic acid levels. We touched on the non-modifiable risk factors, but the modifiable one, weight loss appears to be the most, particularly in the study that was done by Eleanor Baldwin in 2010, looking at the effectiveness of the diet. 10 episodes were accounted for by patient-reported lapses in dietary compliance, And then there were 4 episodes secondary to surgical or medical admission, 3 due to infection, and in 4 of the cases we were unable to find the cause. How often do we monitor Phytanic acid? Now, our principle has been that we would monitor Phytanic acid based on whether it would make a difference in terms of management, or it would have an impact on management. So we normally measure Phytanic acid every 6 months when we see our patients in clinic. And we've noticed over many, many years that the levels seem to be fairly stable within a ballpark of 20% variation among individual patients. However, if the symptoms or neurological symptoms are getting worse, or if there is associated weight loss, either in planning or intended or unintended, or if there's an intercurrent illness that might impact on levels, particularly regarding decisions for plasmapheresis, then we would measure the levels a bit more frequently. Plasmapheresis, there is quite a bit of debate around this. We don't routinely use it in our service. However, we would consider it if we are acute or worsening neurological symptoms, if there are cardiological symptoms, or if the Phytanic acid levels are very high. There is a German group that does plasmapheresis quite often, and they have reported on 4 patients who have had plasmapheresis very often. However, the frequency is bi-weekly for life, and we don't actually have a comparative group at the moment to compare plasmapheresis versus not plasmapheresis, and we would need to do further research weighing up the pros and cons in terms of the role of plasmapheresis in these patients with ARD. We have started to prescribe emergency regimes more routinely for our patients in our clinic, and the aim is really to prevent a catabolic state that might lead to release of stored Phytanic acid into the circulation. And what is our rationale for this? Our rationale is that this is our standard practice for other disorders of fatty acid oxidation defects. And also there is some very good data that came out on this paper, which was published in 2003. So what were the main take-home messages of this paper? What they did was they fasted 5 patients with ARD who voluntarily fasted for 56 hours. Of course, we would not be allowed to do that now. But the plasma Phytanic acid doubled within 29 hours. 3 of the patients felt unwell after that. 1 patient lost 8 kilos, 1 patient was unwell for 12 weeks, and 1 patient had leg cramps for 3 days after. We think the higher the baseline of Phytanic acid, higher the risk in terms of doubling and the side effects that might have. So what do we do in terms of emergency regime? We give a 20% glucose polymer drink, which we advise patients to take regularly if they are not eating and drinking until they are eating and drinking normally. And if they are not able to tolerate orally, or if they have to be nil by mouth for any reason, such as surgery, etc., then we would advise IV glucose. And I think the important things are to avoid to give IV glucose at 2 mL per kilogram per hour, keep glucose levels between 6 and 10, to give insulin rather than slowing the rate of infusion if the glucose levels are persistently high. And if there is a fluid deficit that needs to be corrected, then that should be corrected with normal saline. I think it's important to add as a caution that the median age of our patients with ARD is significantly higher than most of our other patients with other fatty acid oxidation defects. And a number of our patients do have comorbidities like diabetes or reactive hypoglycemia or ischemic heart disease. And therefore, it's important to take this into account when prescribing the emergency regime. And we do alter it sometimes for our patients. And a multidisciplinary approach to management is highly recommended. What do we normally do for surveillance? Well, I think the most important surveillance is around symptomatology for neurological problems. And towards that, we would normally ask for a hearing test, particularly regularly audiology scans from the age of 50 onwards. Neurology, it's mainly guided by symptoms. We have asked for baseline nerve conduction studies on some of our patients. We did wonder whether we should be doing brain MRI scans as a baseline, but we haven't made that a routine practice, more because we're not sure of how to interpret the brain MRI scans or how we would change management based on that. With regards to eyes, all our patients are seen in the eye clinic, and I think that's been discussed in detail by Prof. Leroy in any case. Cardiac manifestations, there have been a number of case reports talking about cardiomyopathy. Usually we think it's a late presentation, particularly in patients who are not well controlled. Arrhythmias are more of a problem acutely due to high Phytanic acid levels, but they can also occur as a complication of plasmapheresis. So in our clinic, cardiac monitoring is symptom-based. We would advise cardiac monitors in the acute phase if patients are acutely unwell. And we are considering whether a baseline cardiac MRI, when stable, might be something that we might want to think about in the future. A number of other case reports, single case reports are available in the literature. As we know, ARD is rare, and the reports are a handful of reports, some talking about renal tubulopathy, which can sometimes be seen in patients with Refsum's disease. There has been one case of leukodystrophy or white matter changes in the brain in one patient, and reversible vestibular neuropathy has also been described in one patient in a case report. In the clinic, we would normally do a general systems review, and any further surveillance or investigations would be guided by patient symptoms, depending on how severe the symptoms are and what investigations are required to further characterize them. So that's the end of my presentation. I'm happy to take any questions and answer any questions that you will have after this. Thank you.
Thank you, Dr. Ramachandran, for the great presentation. We will now start the Q&A portion of the webinar. So I'll start with the questions that we have so far in the Q&A box. And then for those that are on the phone, you'll press *9 to raise your hand. And so we'll go from here. So we do have a couple up on the screen, Dr. Ramachandran. So the first one is there any evidence for those who were diagnosed later in life when developing full-blown symptoms after weight loss that some neurologic symptoms reverse? And is there any suggestion as to how to manage peripheral neuropathy in feet and legs?
Sure. So going by the history of some of the patients who presented to the Refsum Disease Clinic, there is a reversal of neurological symptoms, particularly in the early stages when they present acutely. There is some patients do have residual neurological symptoms that remain. And in terms of managing peripheral neuropathy in feet and in legs, it's no different in adult Refsum disease versus any other peripheral neuropathy. So we would be symptom managing using medications like gabapentin if there is pain. And also, I think the important thing is that we would want to, just because they have peripheral neuropathy, we don't assume that this is due to adult Refsum disease. We want to also measure things like B12 because that is a common cause of peripheral neuropathy, and we would want to make sure that any reversible or any other modifiable factors that might have an impact on peripheral neuropathy, including poorly controlled diabetes in patients who have that, is also looked at.
Great, thank you. So the next one is from Dr. Leroy. So he says, Dear Radha, thank you for your brilliant talk, very informative and crystal clear. He says, one of the factors that you mentioned to keep PA levels under control is weight loss. However, we know that starvation, catabolic state is a risk factor for acute PA release. How would you advise to have a strict control of weight loss by a dietitian and personal trainer who is aware of ARD?
Thank you, Bart. I mean, as you know, that evidence again is sort of limited. What we do in our clinic is we are very careful to advise patients not to actively lose weight without our dietitians being involved right from the beginning. I think the baseline phytanic acid level is an important factor. So we would think that somebody, for instance, who has a phytanic acid level which is 50 is perhaps less at risk than somebody who has a baseline phytanic acid level of about 400 or 500. I think we would have to it's a difficult one. We haven't actually had any patients where we have really looked to see how we would do the weight loss without by measuring serum phytanic acid levels. We don't have that data, but what we would say is very, very gradual weight loss under strict supervision with our dietitian. But we don't have a very strict or well-defined protocol. It is more sort of based on individual patients and monitoring their phytanic acid levels.
As a follow-up question to that, Dr. Ramachandran, would you recommend more frequent phytanic acid level testing if someone was starting, a weight loss plan or, a new exercise plan or, in changing their diet in some way? So at times there's, recommendations from dietitians, say a gut diet to remove fungus, say from your gut or things like that, where there might be a radical change in diet necessary to do that. Would you recommend more frequent PA testing?
As I showed you on the slide, one of the difficulties, so we have some conditions, for example, in patients with phenylketonuria, for instance, we measure phenylalanine and the levels would change almost on a daily basis, and we can make dietary adjustments based on that. One of the difficulties with phytanic acid is that we've got huge stores in the adipose tissue and the liver that we can't really make an estimate of on a regular basis. And normally, for example, even if patients have plasmapheresis, the levels actually rebound back, and that's related to what is stored in the liver and the adipose tissue. And we also saw from the presentation that it takes 1 day for the phytanic acid levels to double, but actually takes a month for it to clear. So it's very difficult to estimate in terms of what or how the acute changes are having an impact on the phytanic acid level, because there is a big lag, if you see what I mean. But if patients are really unwell or if they are making very acute changes, perhaps doing it on a monthly basis and looking at the trend for a short time does make sense. But I think one of the difficulties is the lag between the event that has caused the change in the phytanic acid level and then the month-long period that it probably takes for the levels to sort of come down. Does that?
Yeah, that makes sense. And just figure that if someone's going to do something that potentially could release, phytanic acid from their tissues, maybe more frequent monitoring would be beneficial. It might be delayed, in seeing the reaction, but maybe there'd be benefits in doing so. So we got another question here. It says, what are your thoughts about COVID-19 and ARD, and what are your recommendations about the vaccine?
Sorry, Christy, I think we lost.
Can you hear me?
Lost you there. I don't know if it was just me or. Yeah, I can hear you now.
Okay. It said, what are your thoughts around COVID-19 and ARD, and what are your recommendations about the vaccine?
So again, that's a very difficult question. I think the way to think about it is that our patients, on average, in our clinic are in the older age group. So having COVID, and if they fall seriously ill with COVID, there is a significant risk with that. And if they fall significantly ill with COVID, then it is likely that they're going to reach a catabolic state, which is going to release phytanic acid, and it is going to worsen the adult refsum disease as well. So on balance, I think taking the vaccine is, in terms of risk versus benefits, the benefits far, far outweigh the risks for patients taking the COVID vaccine. We have had a couple of patients who have reported feeling unwell after taking the vaccine. And again, purely theoretically, it is possible that there's a little bit of serum sickness that happens, which is normal reaction to taking the COVID vaccine. And so we would recommend that if they're not eating and drinking well, then perhaps to use their emergency regime for a couple of days, especially if they're unwell, to tide over that period.
Okay, thank you. The next question says, should children of Refsum patients be monitored?
So Refsum's is a recessive condition, which means that for someone to be affected, they need to get 2 copies of the mutation, 1 copy from mom and 1 copy from dad. Children of patients with Refsum's disease, because it's so rare, it is very unlikely that both parents will have Refsum's, unless it is like the situation like the case report that I presented. So the patient's children will be carriers and therefore not affected, and therefore do not normally need to be monitored or followed up, as far as we know.
Okay, thank you. So the next question is, why on average do PA blood tests take longer in the UK when other countries get results back sooner?
I will pass that on. I know that has been a complaint for the UK patients. I think it has been particularly bad during this COVID situation, and I will pass that down as a complaint to our laboratories, and I will get back to our UK patients with regards to that.
I would say I don't think it's only the UK that it's delayed. I think there are other countries in Europe where it is delayed as well. I think they batch the samples up versus processing them immediately. I know in the US they process them immediately and I get my results back right away, but I don't think it's only the UK, if that makes you feel any better. I think it's just a matter of, should it be immediate versus batched, I think is what it comes down to.
So thank you for saying that. That does make me feel better. And there are very good reasons for batching the samples. It's just because of the way the samples are run. They need to run quality controls and things. And I don't know how it works in the US, whether there's one center that does all of them, and so they have enough in one day to do it all on one day. Again, because it really depends on what we do with those phytanic acid levels and how do we change that management based on the phytanic acid levels. Most of the time, our patients, we are monitoring it to see whether there are any trends rather than acting immediately on one phytanic acid level. And therefore, I know it is annoying to wait for 2 weeks to get the results back, but in terms of management, whether that makes that much of a difference, I'm not sure. I think what we will try and work towards is to see how, once the results are available, I have to say there's also a delay from the results being available to us clinicians and we communicating that to our patients. And perhaps we could look at ways in which we reduce that so that they get the results back quicker.
I know personally I'd like one of those glucose monitor type things that I could just monitor it on my own, but I know that's not going to happen anytime soon. So yeah, so that would be great. I think one of the other things that people have been challenged with is to be able to actually get the test. I think that's also been a challenge. And as you say, from a COVID perspective, probably even more challenging. So that's something to look at in the future as well. Another question would be, would you recommend weight loss at a very low rate in PA levels over 500? Or would you not recommend any weight loss, not even 1/4 kilogram a week, although that is difficult to control?
So I think I think we have to look at the situation holistically. It depends on what that weight loss is for, what it means for our patient, what are the other risks, and what are the other comorbidities. So my advice would be to get in touch with the dietitians. I don't think we should be sort of having a generic rule in terms of phytanic acid levels and weight loss. I think it should be more assessing what the implications of the weight and the weight loss are for individual patients, and that's best done at an individual level with discussions with dietitians and physicians to make sure we support our patients in doing what they want to do in terms of weight.
I think one of the challenges I hear from patients on speaking to, say, a dietitian or going to their local clinic is they're not as lucky to have the Refsum experience that your clinic has, you know, in working with Refsum patients. And so, you know, maybe one of the things that we can work on as we go forward is, you know, how do we help support that education so that they actually, the person that is providing the advice to the person with Refsums, that they can provide good quality advice around that. Because I think we for those of us who aren't as fortunate to be in the UK and be in your clinic, right, we don't often get that same type of support or advice.
The difficulty is that because Refsums is so rare, and as you've rightly pointed out, there are so many unknowns still, and you know, we will continue to work on it, but we don't have all the answers. I think the best way to do it is if a patient is going to see a physician outside, and if they feel that our help would be helpful, then we would much rather the physicians reach out to us so that we are able to have that discussion and help the patients that way. Because actually, it's very difficult to make a generic statement because every individual patient is so different.
Absolutely. I think we've definitely seen that. Obviously, PA levels can be very different. You know, what might be my normal level and safe range might be different than somebody else's. So I think an individual plan is obviously appropriate. And obviously, if your team is willing to provide some support to those doctors providing, you know, guidance to patients, that's great. So another question. Is there a powdered form of the emergency regimen with a long life that could be kept on hand if necessary? Of course, not all the same products are available in all countries.
Okay, so I'm going to have to refer to our dietitians to that, and I will get back to you on that. But as far as I'm aware, we do the sachets that we give our patients do have a relatively long shelf life, and they come in little individual sachets precisely because it's much easier to carry around and put a couple of sachets in the handbag or when you're traveling. So what I can do is ask perhaps Sarah Furman to put a little or send you some information, Christy, that can be sort of shared on the website.
Sure, that would be great. So a question, and I know I've benefited from this, so I figured I'll ask this question so that the rest on the phone can benefit as well. Is I know there's times when people need a surgery for different reasons. As an example, I needed shoulder surgery, and I, was fortunate enough to reach out to you, and you provided guidance. Could you share, the clinic's guidance when a person with Refsum requires surgery? Because as you showed in your document, that can release because someone ends up fasting and is not aware of the protocol. But maybe you could share a little bit of your guidance or clinic's guidance on that.
Sure. So essentially, and again, we can sort of draft something and put something on the website if you like. But I just want to use it as a caveat to say we do it on the basis that that is what we do for other conditions with fatty acid oxidation defects, and we do it because of the results of that study, which showed doubling times at 29 hours. So essentially, the principle is to give IV glucose and give it in enough quantities to prevent catabolism. And that's the principle. But I think the caveat again is that if patients have got diabetes or if they've got heart disease where they need to fluid restrict, then obviously that needs to be taken into consideration when making individualized plans. But we can put something for the website again and send it over to you.
Yeah, because I know the plan that you provided did well by me as well as other patients that have since used the plan that you provided me. I think it's beneficial because we know that there are some patients who did not follow that type of a plan and had a big release and needed something like plasmapheresis to be able to bring their levels back down. So I think that's a great benefit to have that protocol. So I've got another question here. So intravenous parenteral nutrition based on liquid solutions exist without PA. That is what we have given our patients of ours that have undergone heart transplant. Maybe we should also enlist these TPNs as an advice to the ARD community. Lipid solutions.
So there are TPN solutions and NG feeds that have low phytanic acid, and depending on the needs of the patients, we would recommend that. Usually when patients are having surgery, you know, it's a matter of hours, and usually they are eating and drinking within 24 hours. And so the dextrose solution will suffice, but I completely agree that if someone needs to fast for more than 24 or 48 hours, just giving them glucose is not a solution, and we would be looking for more complete nutritional plans which have got low phytanic acid to support patients who are not eating and drinking.
Great. So I have one question from a caller. So I'm going to press the allow to talk button. So Judy has a question. So Judy, do you want to ask your question? You need to take yourself off mute. Yeah. There you go.
Can you hear me?
Yes, I
yes,
can.
I can.
Yes, thank you. The 30-year-old patient that you mentioned recently,
Yeah.
not seem to have hugely elevated phytanic acid. Is it possible that some other factor to do with refsums than phytanic acid affects the retinas and the eyesight?
Yeah, that's a really good question, Judy. And the answer to that is we don't know for definite, but there are a few things to think about. One is we don't know, the plasma phytanic acid levels don't always correlate with the phytanic acid levels in the tissues. So we don't know whether that has an impact. We don't know what the phytanate in the retina and in the retinal tissues, what the levels are. And I know that there's a group that is looking into that, and perhaps we will have more answers in the future. Also, that is why I thought that the case report that Christy sent over with the pregnant lady with the children, whose children have been put on low phytanic acid diet right from the beginning. Obviously, their control is not that great, but it would be that kind of sort of study where children have been put on low phytanic acid diet in the pre-symptomatic stage, and their phytanic acid levels are low, and then we can see what impact it has on retinopathy. But it is possible that there are other factors. I'm not aware of them, and I think that that's an area for research.
Thank you.
All right, I think that ends our questions. So thank you very much for answering all the questions. Thanks for the audience for asking them. I'd really like to thank everyone for joining. I'd like to thank Dr. Ramachandran for her wonderful presentation and answering everybody's questions. And that ends today's webinar. So thank you, everyone, and have a wonderful day.
Thank you very much.
Thank you.